Hi and welcome back to another video of Medic Notes. This video will be on hip examination in orthopedics posting. So before starting the examination, wash your hands, greet the patient, introduce yourself and gain consent to examine them. For position, we start with the patient standing up, and for exposure, both the lower limbs must be exposed, and ideally wearing undergarments only. So in orthopedics physical examination, the four main parts are look, feel, move, and special tests. So first, by looking at the patient, with the patient standing up, we inspect from the front, the side, and the back. Look for any pelvic alignment, for any tilting of the pelvis, deformities such as short limb or fixed flexion deformity, any muscle wasting, especially at the quadriceps and gluteal muscles, any scars, which is usually seen at the posterior lateral side of the hip, and any swelling at the hip joint. Also, we can ask the patient to walk to the other side of the room and walk back to assess for their gait. And the expected gait in hip examination station would be Trendelenburg gait or antalgic gait. Next, we ask the patient to lie down and we look for any shortening of leg, any fixed flexion deformity, any fixed abduction or adduction deformities. So after finishing with the looking part, then next we proceed to feel. So first feel the temperature over both the hip joints, and next we have to measure the apparent length and the true length. For apparent length, we do not have to square the pelvis, and the distance to measure is from the siphisternum to the medial malleolus of both the left and right legs. So shown in the first picture, the apparent length. Whereas the second picture shows the measurement of the true length of the lower limbs. For true length, we have to square the pelvis before measuring, and the distance to measure is from the anterior superior iliac spine, ASIS, to both the medial malleolus of the lower limbs as well. So the difference is true length, we need to square the pelvis, and the distance to measure is also different. So how to square the pelvis? So first, put your forearm across the patient's to ASIS, and then we use our other hand, the right hand, to hang both the patient's thighs at the knee joint. And we move the lower limbs left and right until you feel both the ASIS are at an equal position, where both the ASIS do not move upon moving the patient's legs left and right. Then the pelvis has been squared. This is done before measuring the true length. Next, we proceed by doing a Galeazzi test, and this is done when there is a true length discrepancy. So we have to determine whether the shortening of the limb is below or above the knee. And this is a picture showing how we do the Galeazzi test. So the hips are flexed at around 45 degrees, knees are flexed at 90 degrees, and we side of the patient. So if you see the first picture, the right leg is the dotted line and the left leg is the black line. So if the shortening is below the knee, then the affected knee will be distal, shown in the second picture. So the dotted line is distal. So it means the right leg is distal, so there is shortening at the right leg, shortening below the knee of the right leg. Whereas if the shortening is above the knee, shown in this first picture here, the dotted lines, then it means the affected knee is proximal, so shortening above the knee. So these two pictures, the first picture, shortening is above the knee, whereas the second picture, shortening is below the knee. And the defective leg is the right leg. So after doing the Galeazzi test, there is also a test called the Bryan's triangle. And this is to determine whether the shortening is above or below the greater trochanter at the hip joint. So we have to locate the ASIS, which is the anterior superior spine, and the greater trochanter, tip of the greater trochanter, shown in this picture here. And we draw two perpendicular lines, and this will be the distance to be measured, which is the base of the triangle. So we measure for both the lower limbs. If it is equal, that means the shortening is below the greater trochanter, because there is no shortening of distance at the is unequal, then it means that side would be affected. The affected side, they will have shortening above the greater trochanter. Another test is the Thomas test. This is done for any fixed flexion deformity. So we place one of our hands at the lumbar region at the back of the patient, so between the lumbar region and the bed. Flex the normal leg at the hip and knee until we feel that the lumbar lordosis is obliterated. And then we look at the other leg for any fixed flexion deformity. After doing these steps, we repeat on the other side. So after done with the feel part, then we move on to the move. So these are the range of motions that we have to check for, including flexion of the hip joint. And this bracket is the normal range of the degrees. For example, in flexion, the normal range would be 0 degree to 140 degrees. Other movements that we have to check for are adduction, adduction, external rotation of the hip, internal rotation, and also extension of the hip. So take note that these two, abduction and adduction, which are highlighted in red, these two we need to square the pelvis first before checking this range of movement. So after doing those examinations, in discussion part, this is a commonly asked question by the examiners, which is to explain the Trendelenburg sign, which is one of the common gaits seen in hip station. So this picture shows, the A picture shows a normal pelvis, whereas the B picture shows there's Trendelenburg. So for explanation of this sign, when we are walking, the opposite gluteus medius muscle will lift up and maintain the pelvis from falling down, so the leg can be raised up as well. However, Trendelenburg's gait happens when this is not achieved, and it can be due to various causes, which I will explain about it later on. So, for example, the pelvis will drop when one tries to lift the leg up during the swing phase when walking, which is shown in the second picture, the Trendelenburg sign. So the pelvis will drop. So to compensate the pelvic drop, the individual will then exaggerate their ipsilateral shoulder shrug to maintain balance. There are a few causes of positive Trendelenburg sign besides the muscle problem. So muscle problem such as gluteus medius weakness can cause this sign. Other causes include nerve problems such as superior gluteal nerve, which innervates the gluteal muscles, fulcrum problems such as hip osteoarthritis, hip subluxation or dislocation, and even DDH. Level problems such as fracture at the neck of femur or coxavara can cause positive Trendelenburg sign as well. So that's all for this video. Thank you.